Good evening. It's wonderful to have so many of you across the country with us today to discuss today's topic, what veterans need to know about prostate cancer and how to get care in your community. This webinar is brought to you by Xero, the End of Prostate Cancer, in partnership with Intuitive. I'm Allie Manson, Vice President of Government Relations and Advocacy at Xero, and I'll be your host today. I want to thank our featured speakers, Dr. Minaj Zik, Joe Duran, and prostate cancer survivor and veteran Chris Proven, for sharing their time, expertise, and experiences with us today. I'll introduce those three men shortly, but before we begin, I'd like to go over a few housekeeping items. Today's webinar is being recorded. It'll be posted on our website, xerocancer.org, tomorrow. As soon as the webinar ends, you'll see a link to a survey, and we would love for you to participate so we can get your feedback on this event. Tomorrow, you'll also receive an email with a link to the recording and the survey. You can also ask questions through the Q&A box. Ask a question at any time, and we'll try to answer as many as we can with our speakers at the end of the webinar. So for those of you not familiar with Xero, the End of Prostate Cancer, we are the leading national nonprofit with the mission to end prostate cancer. Xero advances research, improves the lives of men and families, and inspires action. If you're new to the Xero community, we welcome you and we're so glad you found us. At Xero, we offer an array of extensive patient support programs and educational tools that are offered at no cost to patients and families. And if you or someone you know is in need of resources at any time during a prostate cancer journey, please share these resources and programs and let them know we're here to help. So I do want to spend just a moment highlighting a few of Xero's support programs. Xero 360 is Xero's comprehensive patient navigation service that provides individualized case management to help patients and their families connect with financial assistance, navigate insurance, and find other kinds of support, including emotional support and even transportation assistance. Xero also offers peer-to-peer support through our mentor and caregiver connector programs. We match patients and caregivers with someone who has been on a similar journey to provide ongoing one-on-one support. Xero Connect is our private online Facebook support group where you can connect with others affected by prostate cancer. You can learn from their experiences and ask questions from patients and loved ones across the country. So Xero's educational suite is full of informational sheets, questions to ask your doctor, patient toolkits, up-to-date content on the latest in diagnosis and treatment information. Our website also houses a nationwide database of sites who offer free or low-cost prostate cancer screening. And for veterans, if you visit www.xerocancer.org/veterans, we have additional information about your risk and many of the things you'll learn tonight. I would like to take another brief moment to thank Intuitive, the generous sponsor of today's webinar. The Xero team is extremely grateful for this partnership. Right? We don't get to make this kind of content without the support of our friends and partners. Today's webinar will begin with a brief welcome from Congressman Greg Murphy, followed by Chris Proven, prostate cancer patient and veteran, who will share his story. Then we'll hear from Dr. Minaj Zik on what prostate cancer is, who's at risk, and what treatment options are available. After Dr. Zik, we'll hear from Joe Duran, the Director of Policy and Planning at the U.S. Department of Veterans Affairs. He'll share information about accessing prostate cancer care in your community through the Community Care Network. Once we hear from everyone, we'll take questions from the audience. So please feel free to type your questions at any time into the Q&A box located at the bottom of your screen. We'll do our best to get to each question. So let's get started with introductions. Gentlemen, if you could please turn on your video. All right. It's my pleasure to introduce Christopher Proven. Chris is a retired U.S. Navy aviator and currently the program manager for the International Partner Maintenance and Pilot Training Program. Next, we have Dr. Minaj Zik. Dr. Zik is an associate professor at the University of Maryland School of Medicine, and he is the director of urologic oncology and robotic surgery. He's also the chief of urology for the Maryland VA healthcare system and has been a VA surgeon since 2015. Finally, we have Joe Duran. Joe is the director of policy and planning for the Veterans Health Administration Office of Community Care. In his role, Mr. Duran was successful in the OCC's successful implementation of the Mission Act in 2019. So please join me in thanking Chris, Dr. Zik, and Joe for joining us. And Chris, you have the floor. Oh, wait, I'm going to back up 1 second. Chris, we're going to hear from Dr. Murphy first.
Hello, everyone. I'm Dr. Greg Murphy, a physician and member of Congress. I want to thank Xero for having me here today to talk to you about the important issue of prostate cancer screening amongst veterans. I represent the 3rd District of North Carolina, which is home to over 89,000 veterans, with more moving to the district every year. In fact, my district has the 6th most veterans of any district in the country. As a practicing physician and experienced lawmaker, early detection and patient education, as well as advocacy in the veteran community, are incredibly important to me. Did you know that veterans are twice as likely to be diagnosed with prostate cancer than the general population? Much of this is believed to be due to the exposure of Agent Orange and other herbicides. As a member of the Health Subcommittee of the House Veterans Affairs Committee, I'm committed to addressing these issues head-on. Last Congress, I proudly supported the Veterans Prostate Cancer Research and Treatment Act, which would establish a national clinical pathway for prostate cancer treatment. All leading experts agree that early detection is the single greatest indicator to improve healthcare outcomes. To that end, I've also co-sponsored a bill that will provide for Medicare coverage and payment for multi-cancer early detection screening tests. If passed, this bipartisan legislation would allow early detection and coverage for over 50 different types of cancer, including prostate cancer. This legislation will be a game changer in early detection by expanding patient access to life-saving technology. Additionally, I recently introduced the Facilitating Innovate Nuclear Diagnostic, the FIND Act, with 3 of my colleagues in the House. The FIND Act would change the Medicare reimbursement structure to allow patient access to imaging tools and radiopharmaceuticals to improve diagnosis. I've personally used these diagnostic tools in my urology practice, and I know how they improve diagnosis and outcomes. Cancer does not discriminate, and if you've never been diagnosed, you must likely know someone who has. As a practicing urologist who has diagnosed and treated many men with prostate cancer, it is my hope that one day we have better treatment options and one day a cure. That is why I'm introducing legislation that will establish a committee to coordinate and streamline activities across the National Institutes of Health and other federal agencies relating to prostate cancer. It's a shame that veterans have to serve in our country honorably and have come back and dealt with a variety of healthcare issues. We must do everything we can to educate and inform veterans about potential health risks and provide services for meaningful patient care. I look forward to working on veterans issues with the Department of Veterans Affairs as a member of the Veterans Affairs Committee, and I will continue to advocate for our veterans every single day in Congress. Thank you to everyone at Xero for asking me to speak to you, and I want to thank all of you veterans watching this video for your service to this great nation. Thank you all, and God bless.
And we are grateful to Dr. Murphy, not only for joining us tonight, but for his leadership on both veterans and prostate cancer issues in the House of Representatives. So I'm going to now, for real this time, hand things over to Chris Proven.
Okay, good evening, everybody, and thank you to Xero for giving me an opportunity to speak tonight and talk about my story and how I came to this great organization. As mentioned on my earlier bio slide, I was 20 years in the Navy as a Navy pilot, flew the F-14 Tomcat for 3 tours, including a combat tour. Each year, I underwent annual flight physicals. I held a Class 1 medical certificate, which is what you would need to fly airlines. And I had no family history of any early cancer. In fact, I have not had a grandparent pass away below the age of 90. So I had a very, very healthy family and no other issues. About 9 years after I retired, every year I conducted my own pseudo flight physical with my primary care physician. I would go in there and request just about every test under the sun because I wanted to know early if there was any issues. Things like cholesterol, testosterone, A1C, that type of stuff. The primary care physician that I had a family history of prostate cancer. His father, his brother, and he was pretty sure he was going to have it. In fact, he said he had elevated PSAs and wanted to know what mine was. And I'm like, what is a PSA? I had no idea what that was. He explained it to me and said, well, let's get a test, find out where you're at. You're only 49, but we'll find out what your baseline is, and then we'll keep an eye out over the years. Well, that came back at a 4.7. So he was quite alarmed at that and sent me to his urologist. I underwent a biopsy. The biopsy came back as one core positive with a Gleason score of a 3.3. I also went and did some genetic testing on the biopsy and did a targeted MRI later in the year just to confirm all this information. The clinical stage, as you see, was stage 1, very low risk. The genetic testing came back very positive. It was a very, very low risk, and we opted for the active surveillance. Every 3 months, I'd go in for a PSA test. They never got above 6. I was around 4.5, 5, 5.2. So at the 1-year mark, I went in for a second biopsy, and this time it came back quite a bit more aggressive. 2 cores positive, higher Gleason score, and a severity that he was just very uncomfortable with. We, having had a year to understand what was going on, I did a lot of reading. I came in armed with all kinds of information. I wanted to talk about seeds, radiation, proton beam, because it sounded cool, all kinds of stuff. And he looked me right in the eye and said, no. He said, you're going to go down to Celebration Health in Orlando, Florida, and talk to Dr. Vipul Patel, and you're going to get a consult about getting it removed. He said, there's no reason to deal with that. When you have it possibly contained, let's just get rid of it and be done with it. And I'm very glad we did. So I went down there, he looked at it, and even the surgeon at the time looking at the results of all these biopsies wasn't all that concerned. He even recommended, well, we could wait another year and take a look at this. I decided I'm in very good health, pretty strong, physically fit. Let's go ahead and do it, and I'll just deal with the aftermath of it. It's not going to get any better, so let's get it while it's getting good. As it turned out, the pathology report came out. He was quite surprised. It was stage 3. It was on the periphery. He said I was about 6 months to metastatic bladder cancer, which is where it was heading. So luckily, though, the surgery was a complete success. I was clear. And since then, that was in 2017, I've had undetectable PSAs ever since. And when I say near full function, I'm at where I figured I would be at 55. So I'm quite happy with that. So why did I, why did I join Xero? Well, it was very easy for the first year to just not want to talk about it. In fact, there's members of my family that I really haven't confided in about it. Just, it wasn't necessary. And I felt like, okay, I dodged a bullet, let's just move on. And then I started reading about other men in the news, how they had metastatic prostate cancer, how they died from it, how they've had just years and years of painful radiation and surgery. And so I decided, I didn't know, and it was because of a very astute family care physician that said something. I said, well, I'm gonna be part of the solution. So I found out about Xero through Mike Crosby, who I initially looked at his veterans cancer awareness group, and he turned me on to Xero. And so what did I want to do? Well, I wanted to educate men on the PSA. I know it's not a perfect test, but it's what we've got. It's the best we've got. It's the only thing we've got. And if anything, it'll get you going along the lines of investigating further. I know that a lot of the criticisms of the PSA are the unnecessary procedures and the overly aggressive procedures. However, I feel like, and I've had some confirmation from other doctors, that my path was probably the best path in terms of I didn't freak out, I didn't immediately go and run for surgery. I did all the steps that they felt was prudent prior to coming to that decision through 2 urologists and the surgeon that the robotic prostatectomy was my best case. And I'm glad I did. I don't have to worry about it. 3 months after that surgery, I retained my class 1 medical certificate, and I was able to do commercial flying after that, in addition to my normal day job. So I'm very happy about that. I've talked to a couple of individuals that have found out about this, and they are going for surgery, and they are understandably concerned about their post-surgery response. A lot of men my age, that part of the body is still very important, still works. still enjoy using it. So they are very concerned about that. And there was some advice I was always giving them. Dr. Patel and Celebration Hospital, a fantastic organization. They couldn't have done better for me. They, from the beginning through the procedure, and then the incredible amount of education and support that they give you after the surgery. I did everything they told me to do. The PAC came out, I did everything. And I retained essentially full function to this day. So very happy about that. And I want to go out and tell guys that there is a path afterwards that they may be happy with. Some of the items I've also executed is some emotional support. There are some guys that find out that, well, it has metastasized. And so I try to get them involved in this organization, that they can come in there and they can look at what's coming down the road, what kind of procedures they can go to, what kind of hopeful outcomes they can get, and to seek multiple opinions, get out there and talk to different doctors and see different procedures. Some doctors are set on one procedure, but as we've seen with the Xero organization, there are multiple paths to cure prior to metastasis and much better mitigation after metastasis. So I'm very excited. I got a chance last year before the COVID hit. My wife and I went to Washington, D.C. and walked the halls, talked to Senate and House of Representative staffers. I was amazed. There is not a lot of education about prostate awareness. I would say half the men I talked to had never had a PSA, never knew about a PSA. And I would say a good 40% didn't even know what a prostate did. And I have to admit, I was in that category prior to this whole endeavor. So I think Xero is an excellent organization. I'm hoping to do more traveling and get out there and spread the word. My wife's very excited about being in it. She walked the halls with me. And so this is something we're going to do in the future. So thank you very much for allowing me to kind of tell my story tonight. And if anybody ever wants to reach out to me and have a conversation about it, I'm always here.
Thank you so much, Chris. We
Thank you.
appreciate your time and we appreciate you sharing. I would like to now welcome Dr. Minaj Zik. And you should have the remote to advance the slides.
Thank you very much. I see I can advance them, but there we go. Okay. So thank you, Xero, for putting this on. This is a very important topic and it's a very important population. So I really appreciate the opportunity to participate and address this group. So my name is Minaj Zik. As I was introduced, I'm a practicing urologist, particularly focused in prostate cancer, and I do practice in the VA system. So can you all see my mouse, by the way? I don't know if with this you can see me point or not.
Yes, we
A
can.
little bit, actually.
You can? Okay, good. So here I have the mouse over the prostate. Thank you for responding. So the prostate is a gland, and okay, so it's located in the pelvis under the bladder, and I mean, most people actually don't know where the prostate is, but that's where it is. It's right there and under the bladder, right next to the rectum, and it's along the urinary tract, and it's important for fertility. So there is a phase in life where it's extremely important. It's the size of a walnut, but it can certainly grow with age. And in later stages of life, it has limited benefit anymore. One of the things that does happen is that cancers do form in the prostate. It actually is the most common cancer in men. About 1 in 9 men will be diagnosed with prostate cancer in the course of their life. It is the second leading cause of cancer death in U.S. men. So, sometimes we hear that prostate cancer is not as aggressive as other cancers. However, just due to the sheer volume of prostate cancer that exists, even if only 10% of men are dying of prostate cancer, that actually is a very significant public health issue. Furthermore, in the population that we're talking about today, the veteran population, turns out that prostate cancer is even more common. 1 in 5 U.S. veterans will be diagnosed with prostate cancer in the course of their lives. Prostate cancer rates in the military are twice that of the general population. There's actually some evidence to say that it's actually also more aggressive in this population. While we're talking about disparities, there are a lot of issues with actually disparities in the prostate cancer population. There are racial disparities that we should be aware of because awareness leads to further work and addressing of the issues. African American men are also more prone to being diagnosed with prostate cancer. About 1 in 5 African American men will be diagnosed with prostate cancer in the course of their natural life. It is about twice as lethal in the African American population than it is in the white population. Risk factors. Age is considered a risk factor. So essentially, the older you are, the more likely you are to have prostate cancer. The kind of average or median middle age to get prostate cancer diagnosis is at the age of 72. Western diet is considered a risk factor. It's not clear what within the Western diet. It's thought that maybe the high fat, but it's not really clear, to be honest. Race, as we've kind of discussed a little bit. Family history certainly is a contributing factor. And so men with fathers or brothers who have prostate cancer are more likely themselves to get prostate cancer. And about 15% of all prostate cancers can be attributed to a family kind of inheritance pattern, which is also to say that the majority of prostate cancer, 85% of prostate cancers, are actually not due to family inheritance patterns. In this population, Agent Orange is very important to mention. So veterans exposed to Agent Orange or other chemicals and herbicides in typically the Vietnam or Korean wars are known to have a higher risk of prostate cancer and do get more aggressive cancers. This is very important to know. How do we diagnose prostate cancer? So there are 2 ways to be identified as someone who might be at risk. One is a blood test, and this blood test is called PSA, prostate specific antigen. And essentially PSA is something that is made by normal prostates, but cancer makes more of it. And so if someone's PSA is high, it's either because their normal prostate's making more PSA. PSA is not harmful in and of itself, but the fact that it's high, you want to figure out why is it high. Is it just because normal prostate's making it? Maybe there's inflammation or an infection or something going on in the prostate, or maybe there's cancer there and the cancer is making a lot of it. The other thing that happens is a rectal exam. And so a rectal exam, again, as I mentioned, the prostate is right next to the rectum. And so the physician can feel the prostate through the rectum. Now you can see here, the physician can only feel this side of the prostate. So if there's something wrong over here on the anterior side, we call it, you won't be able to feel that. And so it is a limited test. However, if you feel an abnormality such as a hard spot or some kind of bump, this is a reason to get this checked out. If someone is considered at risk for having prostate cancer, either due to an abnormal PSA blood test or a rectal exam, you can get a prostate biopsy. Prostate biopsies have historically been done in kind of a grid-like fashion through a transrectal approach where the needle is brought in through the rectum. However, now there is emerging approaches where we're doing these things called transperineal biopsies, which there are pros and cons to doing that. There are less infection risks with transperineal prostate biopsy. If you are a patient who is considering these types of things, this is something to ask about. The other thing that has really emerged is the use of MRI, ultrasound fusion prostate biopsy. So as I showed in the previous slide, the way that prostate biopsies were typically done was kind of in a grid, random fashion where you were just hoping to catch the cancer. But what we can do now is we can actually get an MRI to give us a map of the prostate. And the radiologist can look at the MRI and say like, oh, this area over here, that looks a little concerning, the area with the little stars on it. And then with this technology called a fusion platform, we can actually aim the needle kind of like a bullseye at the area that looks concerning and get targeted biopsies, which are found to be more reliable in terms of catching aggressive cancers. Once a biopsy is collected, the next thing that happens is that the tissue is looked at under a microscope, and a pathologist will give it an aggressiveness score, which is called a grade. And the grading system goes from 1 to 5. And I might be getting a little bit in the weeds here, but essentially they take the most common and the second most common patterns and give it a overall score. So the score goes from 6 through 10. And there's a newer system that goes from 1 to 5. But either way, what the point here is that the grade gives it an aggressiveness score, and something that is, and then that aggressiveness score can be compiled with other types of information, such as imaging, where you can have, like I mentioned, a prostate MRI, a bone scan, if there's any concern that it might have spread, an Axemin PET or a PSMA PET scan. There's actually, this is a pretty new technology, and there's actually a clinical trial within the VA system in LA studying this if you happen to live in that market. And then biomarker tests. And all this information is brought together and gives a risk stratification. So you're ultimately diagnosed with something called like low risk prostate cancer, intermediate risk prostate cancer, and high risk prostate cancer. And so once you understand where your risk falls, then the conversation occurs regarding treatment options. And for low risk prostate cancer, active surveillance is actually a very reasonable option. This is where we keep an eye on the prostate cancer, and we just wait to see if it's going to act any more aggressively, if it's going to just progress or do anything. It turns out that half of prostate cancers are actually low risk and can simply be watched with no harm done to the patient. And this is well proven by long-term studies on thousands of patients. However, then there's options such as surgery and radiation and other things, which I'll go over in a second. So active surveillance has been demonstrated to be a safe, effective method for managing prostate cancer in properly selected men. And this is typically your low-risk population. It involves regular follow-ups. This is, as the name implies, active surveillance. It's not that we're going to ignore it or we're not going to do anything about it. It's that we're going to actively keep an eye on it. It involves regular follow-up with PSA, rectal exam, and prostate biopsies, and also MRIs. I would add here. About 15 to 40% of men will progress and will end up requiring definitive treatment. When I say, active surveillance has been historically underutilized. About half of men half of eligible men get active surveillance. Active surveillance can be very good in a way that it avoids complications related to treatment. And like I said, is a great option for people who are good candidates. Now, if you happen to have a more aggressive cancer, then treatment is the right thing for you. Surgery is very effective, as is radiation. Robotic surgery has really kind of emerged as the standard treatment. It is a form of minimally invasive surgery that can be used to treat prostate cancer. What I tell people, I do robotic surgery myself. What I tell people is that my hands are this big. And so for me to operate with my hands, I need to make a cut big enough to fit my hands into the abdomen. With the robotic platform, the hands are about the size of my finger. And so to get that into the abdomen is a much smaller incision. The robot has evolved dramatically over the years. It's become more high definition. The instruments work much more smoothly. You can even have robotic surgery now all through one hole called single port robotic surgery. Many of the VAs across the country now have robots, and the surgery can be done robotically. The thing to know about surgery is that there are side effects. Major side effects are urinary leakage and erectile dysfunction. Radiation is a great alternative, and some people may be the preferred option. There are different types of radiation. Radiation essentially is a way of shooting energy beams into the prostate and killing the tissue by depositing the energy into that area. When you're getting radiation, you can't feel it. It's a very gentle treatment on the body, but it is working on the target tissue slowly and steadily. You can have radiation from the inside out with radiation seeds that are implanted into the prostate. You can have radiation that shoots from the outside in. That's like external beam therapy or proton beam therapy. Typically, this is done in little bursts. The seeds are done like a procedure where they're implanted in one time, whereas the external therapies are usually done, every weekday for anywhere from 4 to 8 weeks. It is optimal for older or sicker men with other medical issues. It's safe and well tolerated. The side effects, most prostate cancer treatments, to be honest, have side effects. It's important to know that and be aware of that going into it. The side effects tend to be not so much the leakage as you see with surgery, but rather urgency, frequency symptoms, and again, erectile dysfunction is possible. For people with more aggressive prostate cancer, radiation or surgery may not be the best option. Sometimes hormonal therapy is what's recommended. Hormonal therapy can also sometimes be used in combination with treatments such as radiation. Testosterone is a very important hormone in the body for prostate cancer. It's almost like I tell people like the food source for prostate cancer. And so by suppressing testosterone, you can actually really shrink and suppress prostate cancer. So this is called androgen deprivation therapy, ADT. It's typically given like a shot, which can last anywhere from 1 month to 6 months in the body. There's other types of ADT as well. There's pills and all kinds of things that you would want to discuss with your physician if this was something that you were considering. There are side effects to having low testosterone levels, typically being tired, having hot flashes. If you're on it long term, for really severe disease, there can be things to talk about in terms of bone health and heart health. For short-term treatments, this is less of an issue typically. And then, way beyond the scope of what I needed, was meant to cover today, but you should be aware that if you do have kind of a more aggressive cancers, especially cancers that have spread beyond the prostate into the rest of the body, there are so many treatments out there now. In the last 10 years, you can see here a map. I talked about local therapy, surgery and radiation. I talked about androgen deprivation therapy, a little bit about this. I didn't even touch base on all this. It used to be that you had one therapy if you failed androgen hormonal therapy. Now you've got immunotherapy and kind of new forms of hormone therapy and radiation therapy and new forms of chemotherapy. And the field is continuing to grow. So there's really increasing numbers and improving prognosis outlook of patients who are diagnosed with prostate cancer. It's important to know as a veteran that most of these are likely available to you. If not available within the hospital, the VA hospital that you go to, they can typically be requested through your community care. So it's important, and I commend everyone that's on this call, who's a veteran, that you are taking control of your health and that you are becoming aware of what's available to you, and that these are the things you can then ask your physician to explain to you more and understand if they are good options for you. Prostate cancer care may be part of your VA benefits, and that's something to look into. In particular, if you have Agent Orange exposure, it's something to note. And that is all I had to cover today. But I'm happy to answer questions if anyone has any follow-up.
I know I have questions, and I'm sure I'm not the only person. So I'm just going to tell everyone, please enter your questions in the Q&A box, and we'll bring Dr. Siddiqui back after we hear from our next speaker, and we'll do Q&A for everyone. So thank you, Dr. Siddiqui. That was really wonderful. Thank you. And finally, we're going to welcome Mr. Joe Duran. And if you wait just about a second, you should have remote access, Joe.
Let's see. I seem to have lost my mouse at the most perfect time. Okay, let's see. I got it back. All right. Let's see. So good afternoon, everybody. My name is Joseph Duran. I'm the Director of Policy and Planning for the BHA Office of Community Care. And I want to thank everybody, similar to my previous colleagues here, for the opportunity to speak today, especially related to the community care program. This is a program that I've been proud to be a part of for the last 15 years. And it's really important to think of community care as a very important program that helps to augment veterans' access to high quality care at the VA, and also as well as in the community when necessary. So our Office of Community Care, our mission and vision, I mean, we believe in these, most companies, they have missions and visions, but we truly believe in our mission and vision. And it really is to play that integral role in VA's high-performing integrated delivery network by delivering innovative healthcare programs that provide access to timely, high-quality, cost-efficient, and well-coordinated community care for veterans and VA beneficiaries. This is especially important in these times, right, where we have an increased number of veterans who are reliant upon the VA healthcare system. And it's very important for our program, the community care program, to be able to help these veterans when VA might not be able to provide the access to care, to make sure that we have the pathways available to let veterans access necessary care in a timely fashion, just like we said, and especially in the case of all types of care, but especially related to cancer-related care. So our vision is to achieve outstanding healthcare outcomes and provide best-in-class customer service to veterans, beneficiaries, VA employees, and community providers. And that's really important because while VA works to provide access for the veterans to the community care, we also have these other stakeholders involved with our community partners in the healthcare providers, as well as our network providers, our third-party administrators that help us administer our network benefits, which I'll talk a little bit about on the next couple of slides. This slide is always a really good way, and I can talk for quite a long time, so I'll try to curb it a little bit here. But the community care, the key components of community care, generally speaking, are this list here that we have provided. And so, as with any program in VA, any kind of government-ran benefits program, eligibility is the most important. And I'll touch on this a little bit later too, but one of the evolutions that VA has undergone in the community care program itself is simplified eligibility criteria for veterans. Prior to 2019, really in any time before then, VA had a whole host of eligibility criteria that made it difficult to navigate, difficult to understand when a veteran could be authorized for community care. And so through our partnership with Congress, we were able to obtain new legislation. Again, something I'll go a little bit into more depth on a little bit later, but new legislation that really helped us simplify our eligibility for community care and simplify those pathways. So that leads into this next component with regard to referral and authorization. So in the past several years, through the past several administrations, we've been very fortunate to be able to continue to fund and make sure that we have cutting edge technology that allows us to make sure we are issuing timely referrals. So we have a new web-based system that helps us manage these referrals. And it helps us to make sure that VA physicians and our community partners and everyone in between have the access to the same information that helps us make sure we are providing referrals and authorizations that contain all the information a physician would need without having to go back and forth to VA. So that's been something that's really been a great advance for us in the last several years. And that leads into care coordination. So care coordination is obviously the most important. One of the goals, as our administrations change and as leadership tends to change in VA, one of the goals that's always great about new leadership that comes in is care coordination and making sure that the veteran is center in every part of what we do. So we always do our best, again, to partner with our third-party authorities, third-party administrators, excuse me, and our community providers, just to make sure we're coordinating the care. It's really important to think of VA not necessarily as care that's not provided in VA, the community care program, but to think of it as again, another piece of VA where a veteran is receiving care in the community, but it's care supported by VA. And that's something we take very seriously and something that we always make sure that all veterans have access to, and we make sure that we're able to encourage everybody and all the physicians to be able to make sure that the veterans, all the care is carefully coordinated. Next is utilization management. So this is another one of those key pieces where we have worked together with our programs to establish standardized episodes of care. And this helps us to make sure, again, like I mentioned, that We're making sure that veterans and the clinicians, they know what care they're allowed to provide. And that allows doctors in the community, as well as our VA clinicians, to get the veterans the care that they absolutely need. The next is our provider network. So we've partnered very closely with our TPAs in developing a high-performing quality network that provides care in all the access areas that are necessary. Now, is our network perfect? Not yet. We're working on it, but like everywhere, there's always going to be access to care issues, especially in rural areas. But we partner very closely with our TPAs to make sure that we have the network in the areas that we can provide, and to make sure that veterans, again, have that access, can get the care when they need, especially if VA is not necessarily able to provide access in a VA facility in a prompt manner. One of the other advantages in working with the TPA is provider payment. So partnering with our TPAs, it allows us to make sure that providers are providing payment or given payment very quickly. So they have a contractual network with the TPA, and the TPA pays them. And then the providers are always happy. They're ready to continue to support veterans, and they don't have to worry about that billing piece. They don't have to worry about getting paid, because we're in the background on the administrative side, making sure that veterans continue to get that care, making sure that our contractual providers continue to get paid. And then we have our revenue cycle. This is a congressional mandate and a congressional authority where we, VA, we bill a veteran's potential third-party insurance when certain criteria are met. And so that's yet another component. And when we get that money, when we receive that money back, it is then channeled back into VA facilities so that they can continue to build upon their capabilities, their systematic capabilities, as well as their infrastructure at existing VAs. So these are the 6 eligibility criteria that I alluded to that we were able to whittle down our previous programs into 6 very specific eligibility criteria, but they're very clear pathways that veterans have in order to access care, community care. Our previous programs, they were largely dependent on a veteran service connected status or other eligibility criteria that were developed and put into place several years ago. And it never evolved and kept up with the time. So we were very excited when the Mission Act passed and we were able to now have these 6 eligibility criteria. And I'll go through them pretty quick because I know I'm going a little bit long. Probably the most important one here is at the very top of the graphic, and that is the best medical interest of the veteran. So if a VA clinician and the veteran decide together that receiving community-based care is in the best medical interest of the veteran, that's all that it takes. That could be in several instances, just like we talked about before. If there's a situation where there's a potential cutting-edge technology that might better serve the veteran, and they're a perfect candidate for that type of surgery, that robotic surgery, like we just talked about, and it's determined to be in the best medical interest of the veteran, then we can issue that referral to a participating community provider, and a veteran can go receive their care in the community. Our other more important eligibility criteria is down here in the bottom right-hand corner of this slide, which is our access standards. So if the care services that are required are not available within our access standards, and you can see here we have drive time and wait time standards, then VA is able to issue an authorization for that care, that referral in the community. So we are able, specifically, primary care is subject to a 30-minute drive time standard, and specialty care is subject to a 60-minute drive time eligibility criteria. And then our wait time standard is if that care is not available in VA within 20 days, that primary care, mental health care, non-institutional care, we have a 20-day standard. And if it's specialty care, like cancer care, like we're talking today, then it would be a 28-day standard. But it's important to note that when a veteran meets eligibility for community care programs, they only have to meet one of these eligibility criteria. It's not all 6. It's not a combination thereof. If you meet one, you're eligible to receive community care at VA expense. And one of the other more important things to remember is if you're a veteran, all you have to do is you have to be enrolled in VA healthcare, which generally, I think most people who are enrolled in VA healthcare, they're well aware. Generally speaking, when you're enrolled, you're assigned a priority group. So most veterans know that. And if you're in one of the lower priority groups, like priority group 7 or 8, you have to agree to receive your care from VA, and sometimes you have to agree to pay copays or certain cost shares as a result of income and eligibility criteria. But even priority group 7 and 8 veterans are eligible for community care based on these 6 eligibility criteria. I would just cover just 2 more of the eligibility criteria here. The care services are not offered by VA. So if it's an FDA approved procedure and it's just not available by VA yet, then that is another reason if again, a clinician believes that it's necessary to receive that type of care that can be referred out into the community. And then a lack of full service medical facility. A lot of our veterans, as we know, are dispersed all across the country. And in certain states, there are not full service medical facilities. So if that state does not have a full service medical facility nearby, generally speaking, those veterans are eligible for community care. And these are just some statistics regarding the community care program since the launch of the Mission Act. I won't cover each of these statistics, but it's really easy to see here that we've provided a lot of care since 2019. Over 3 million veterans approved, over 11.7 million authorizations. And then we have this breakdown of the different types of care that we have approved. But we in community care are very excited about our ability to help issue this world-class program and make sure that veterans have access to care. Real quick, I'll discuss a little bit about community care networks. I think a lot of people are saying, well, gosh, this is great, but how do I know where I'm at? So here's a breakdown of where we are at in the rollout of our community care network. We're fully rolled out, as you can see in the deployments that I have listed in the slide. And you can see each of the regions that are serviced by our TPAs. So we are partnered with Optum, who is a part of the United Health Group. And they are responsible, as you can see here, for regions 1, 2, and 3. And then we continued our partnership with TriWest Healthcare Alliance for our other regions. And so the program has been fully deployed since the spring of 2021, excuse me. But as you can see, that last region 5 rollout in Alaska, that was our last piece. But aside from that area, our program has been fully rolled out within the CCN network now for just about a solid year. And with that, I'll go ahead and pause for now and turn it back over.
Great. Thank you so much, Joseph. And if Chris and Dr. Siddiqui could turn your videos back on, we have questions. We've got lots of questions. Uh-oh, we got a Chris video problem. All right, I'm going to let that sit for a minute, but in the meantime, I'll start with questions for other people here. Oh, maybe that's going to work. So first, I wanted to ask, I think our first question here is from, just for Dr. Siddiqui, and it's, again, remember, you should always talk to your doctor about the right healthcare choices for you, but I'm going to let Dr. Siddiqui answer. After the prostate has been removed, is there a general medical opinion on taking testosterone?
That is a good question. It's a very challenging question. So as we kind of touched based a little bit, testosterone, you can think of the testosterone as kind of like the food source of prostate cancer. So if there is any prostate cancer left in the body, the risk is that the testosterone would wake it up, energize it, help it grow. And so considering the safety of taking testosterone after treatment of prostate cancer is really, it's a tricky topic. And it's definitely something that you need to kind of investigate with the primary team of doctors who are helping take care of this problem. Because there are some situations where it is reasonable and although you'll never get a guarantee that it's 100% safe, it's probably reasonably safe to take it. And then there are other situations where it's really not safe to do so. And figuring out where you fall on that spectrum and how you can navigate things safely is it's pretty involved and unique to each person. But that's what you'd want to talk with your medical team about.
Thank you, Dr. Siddiqui. The next question here is for Joe. So for the question, how do you define best medical interest of the veteran, and who makes that decision? Is it the physician and the patient, or is there a standard? How did I get the answer?
Yeah, absolutely. So the best medical interest of the veteran is determined by the veteran's clinician as well as the veteran themselves. So the provision in the law actually says that the veteran and their clinician have determined together that it's in the veteran's best medical interest. So I know that's probably not the answer people like to hear. They like to hear specifics, but really it is a case-by-case basis, and it depends on what the care is needed. Sometimes those conversations include frequency of care. So in this case, how frequent the cancer treatment is needed. So is it better for that veteran to drive to a community provider a little bit closer, or is it okay for them to continue to commute to a VA facility? So that really is why it truly is a case-by-case basis, but it's never just the clinician saying, nope, this is my opinion, absolutely not. It's a conversation that includes a veteran. And then of course, if there are disagreements, VA has a clinical appeals process that we always have available to us to help get the best outcomes for veterans and our providers.
Thank you. And I've got a question here for Chris. What is the best advice you received in your prostate cancer journey? And alternatively, if you didn't receive any good advice at all, what do you wish you had known?
I actually had a pretty good experience with it, if you could say that. I don't know. I did a lot of research. The doctor had said, go home, do the research, see what works for you. I had bought a couple books, went through the books and stuff like that. So when I came back to my next appointment, I had a lot of information. I really educated myself on the whole scenario, what I was looking at, what I was going to be facing and stuff. So that when it came time to make that decision on which path I wanted to try, the surgery just made more sense to me. At where I was in my diagnosis, to have a potential one and done, which is actually what occurred for me, was my best option. So I guess the best advice would be educate yourself, know what's out there, get several opinions. I talked to 2 or 3 different urologists, including the surgical team. And so I felt like I had a lot of information going into it.
All right. I feel like one of the things I really heard from you as we talked preparing for this was about how much that you were clearly an advocate for yourself, and you lent so much support to others in both the veterans and the prostate cancer communities. I think those are valuable. But thank you, Chris.
Yeah. And I think a lot of people, if they get involved in Xero before, when they first get diagnosed, I did not have any of this. I didn't even hear of Xero until afterwards. I was done with my procedure. And so I think having that support ahead of time would have been nice to be able to talk to other people and see their experiences. I had no idea what I was going to go through, but got a great family and a lot of support this way. But it'd be nice to be able to talk to people who've actually been through it.
Makes sense. Dr. Siddiqui, you mentioned pros and cons of transperineal biopsies, but I think you only mentioned the pros, and we had a question about what the cons might be for a transperineal biopsy.
Yeah, I apologize for neglecting to mention that, but yeah, so transperineal is a little tricky. It can be a little more uncomfortable to do under local anesthesia. A lot of urologists are actually doing them under sedation because of that. It's very much doable under local, but it's I would say it's we're actually doing most of our biopsies transperineally right now, but I will admit that it's a little trickier and can be a little more challenging to go through. There are some unique situations where sometimes the tumor is actually a little harder to reach through the transperineal approach as opposed to the transrectal approach. And in general, it's a newer technique, so it might have more of a learning curve associated, like the things maybe still kind of getting worked out with this technique. It's a few years out now, but it's still, transrectal's been around for 20, 30 years. And so those would be the main cons. I think whether if you're looking to potentially get transperineal prostate biopsy, you'll want to ask if urologist is comfortable doing that technique. You may find that at the moment that there's actually, it's a little bit hard to come by, but it is growing rapidly. And I would expect that it will become increasingly easier.
Thank you. And I'm going to apologize now. There's no way we're going to get through all the questions that are coming in, but please keep sending them. And I'm doing my best to bring up the repeats here. So I've got a VA Community Care Network question here about, Joseph, if you can tell us how you're getting VA clinicians and VA clinics to be more aware of the Community Care Network as an option, because we've got a viewer whose experiences that specialty clinicians have been hesitant to recommend that option for patients.
Absolutely. So generally, all those innovative programs that I spoke about, as we talked about how we've really brought ourselves into the 21st century. So we provide internal training to VA providers to let them know how to authorize community care. Each medical center of VA, generally speaking, they have a community care program based in their facility that are responsible for working through approvals for community care. So if there's ever a question, or if a veteran says, hey, I'm not getting anywhere with this, there's always ways for a veteran to seek out information from the community care office potentially. But we have lots of training that is generally available, and we do try to make sure that all of our clinicians are aware of the options when treating veterans. So if there ever is a situation where maybe a provider is hesitant or they just don't know, generally speaking, we get that kind of through word of mouth, and we work to address that directly with that medical center to make sure that people are aware of what the options are so that we can make sure that we're not interrupting potential very necessary care.
All right, thank you. And Chris, we're going to come back to you. We have a viewer who's wondering if you were exposed to Agent Orange during your military service, and if you think your prostate cancer was connected to that, or what it is that connects your prostate cancer to your service.
No, and actually, that's a good question. I had a conversation up in DC at a luncheon when we had one of the Xero events. No, I was not exposed to Agent Orange or any of that kind of stuff a little bit before my time. But the question came up that they're trying to connect why do we still have a very high incidence of this cancer among service members? And obviously, Agent Orange isn't a factor for anybody that's in the last 30 years or so. I think what the big difference is, though, is the men and women in the military are absolutely bathed in electromagnetic energy all day long. You think of a standard soldier out there, he's got lithium batteries all over him in different gear. He has satellite gear, he has high-powered radios, laser systems. Myself, I had a 10,000 watt radar 5 feet from that area for 12 years. If you think about, you go for a dental x-ray, they put you under a heavy lead apron for a milliwatt of power. This was 10 kilowatts of power. And then you jammer aircraft, your men on the flight deck, the men and women on the flight deck. One thing that I've always, a little story I had was, if you remember the old JVC camcorders where you actually put the tape in the camcorder and played it, the only way you can allow that to work on the deck of an aircraft carrier is you have to wrap the entire camera in tinfoil. Because if you don't, the electromagnetic energy coming off the radar scrambles the tape and you just get static when you try to replay it. So you have to wrap the thing up. So I think the big difference with today's military is the amount of electromagnetic energy that they're exposed to all the time, the industrial environment that they're set. You think about the burn pits in Iraq, you think about the nuclear reactors on half our naval ships, the high energy battery systems and electromagnetic systems you have in Army vehicles nowadays. So I think that is something that needs to be looked at. That's our big difference between our generation of soldiers and sailors and airmen, and the difference that you had in Vietnam where you had chemical exposure, my opinion. So.
Thank you, Chris. And I know there are some ongoing studies looking at the connections between military service and various cancers, prostate included. But we've got time for one last question. And Dr. Siddiqui, this last one's going to come to you. I know we spent more time, I think, on radiation and surgery and active surveillance, but we've got a patient asking about the status of focal HIFU, which you can probably define better than I can, and focal cryotherapy as treatments, and whether or not that's available within the VA system?
That's a good question. So focal therapy is considered emerging therapy. It would most likely be characterized as still experimental. So it is, focal HIFU, high intensity focused ultrasound, or cryotherapy, where you freeze part of the prostate, are ways of treating part of the prostate as opposed to the entire prostate. I think there's a couple of things to be aware of. First, most people are not candidates for focal therapy because they have prostate cancer in a couple of areas of their prostate, not just one area. Most focal therapy, I think, is still often done in the setting of clinical trials. I'm not aware of too much focal therapy being done in the VA system. At least in our VA, it is not currently being done. There may be sites out there that are doing it, but I'm not sure. But in general, it is a little bit hard to come by. It's not covered by insurance typically, so accordingly, I think coverage issues do become an issue for focal therapy, and it's still a emerging area. I think as the data comes in, as the clinical trials are performed, as things kind of solidify, if it is demonstrated to be of benefit, that's really the question right now. Is it, is it beneficial? And that's why it's not covered, and that's why it's not standardly practiced, and that's why it's done as part of research programs. But ultimately, if it is shown to be beneficial to patients with certain types of prostate cancer, I imagine it will become more widely available.
All right, thank you. And I'm going to say to everyone who asked a question and didn't get it answered, feel free to send an email to veterans@xerocancer.org, and we will do our best to connect you to the right person to get an answer or answer your questions for you. I'm sorry we don't have time to answer everything tonight. Whew, that was a lot. But I want to say thank you very much to Chris, to Dr. Siddiqui, and to Joseph, and to our sponsor Intuitive for the informative presentations tonight. To close our webinar today, I'll remind everyone that Xero is here with support offered at no cost for patients and caregivers. And that includes, of course, if you needed to navigate your VA health benefits, that's one of the things that our Xero 360 program can help you with. And we do also have veteran-specific initiatives, and you can learn more at our website, xerocancer.org/veterans. This is the conclusion of tonight's webinar. As a reminder, you'll receive an email with the link to the recording and a short survey to share your feedback. And you might also be wondering what you can do to help veterans with prostate cancer. In that follow-up email, you'll have 2 opportunities to make just a couple of clicks with your mouse. You'll make an impact on policy and education efforts. First of all, you can ask your member of Congress to support legislation that should be introduced today or tomorrow or the next day that will create a clinical pathway at the Veterans Health Administration. And you can also take our survey, not just the one about this webinar, but we're also in the middle of conducting the 2021 Veterans Prostate Cancer Survey to learn more about veterans' prostate cancer knowledge and experiences. And that's open to vets with and without a prostate cancer diagnosis. So please click on that in the email you receive. Thank you so much for joining us tonight. Thank you for your service to our country, and have a good evening, everyone.